You are listening to Med School Radio, and we are discussing thrombosis and hemostasis. And we're now going to talk about the coagulation system and secondary hemostasis, and then we will continue on with our discussion of the case. So the coagulation system and secondary hemostasis. At the conclusion of primary hemostasis, loosely aggregated platelets adhere to the site of vessel injury. Now the enzymes and cofactors that comprise the coagulation system must generate the structural protein fibrin to solidify this mass of platelets into a stable clot. The enzymes and cofactors are absorbed to a phospholipid surface. The coagulation system is a series of sequential limited proteolytic reactions catalyzed by different serine proteases. In general, these serine proteases are inactive or zymogens in the plasma until the coagulation process is set off by vessel injury. Each zymogen is both a substrate for another enzyme that brings about its activation and an enzyme in a succeeding reaction. It is generally agreed that the blood coagulation system, some still call it a cascade, is initiated when tissue factor expressed on damaged endothelium comes into contact with circulating factor 7A. And 7A here, the A means activated. And approximately 1 to 2% of factor 7 is present in the active form, idling in the circulation. Tissue factor 7A forms a complex in the presence of calcium ions. Tissue factor is widely distributed, being found in vessels throughout the body and in fibroblasts. This wide distribution ensures that tissue trauma anywhere in the body will trigger coagulation. This is called the extrinsic pathway because tissue factor is normally present within the circulatory tree. The active factor 7A TF complex then converts factor 9 to 9A and factor 10 to 10A. The newly generated 9A forms a complex with 8A activated by traces of thrombin in the presence of calcium and membrane phospholipids, and subsequently activates factor 10 to 10A. This complex has been termed 10ase to reflect the product factor 10A. Factor 10A then binds to factor 5A, probably activated by thrombin, and joins calcium and phospholipids to form the prothrombinase complex that converts prothrombin to thrombin. It is important to recognize that coagulation is such a potentially devastating process that it must be tightly regulated. Indeed, there is a powerful restraint on the action of the initial extrinsic factor pathway at the tissue factor 7A complex. Specifically, tissue factor pathway inhibitor, or TFPI, promptly turns off the TF7A complex, ensuring that the duration of the action of the intrinsic pathway is transient. The intrinsic pathway permits further production of factor 10A, which represents the beginning of the common pathway of coagulation and will generate thrombin from prothrombin. Two factors from the intrinsic pathway, factors 9A and 8A, must reignite the coagulation process, brought to a halt by the action of TFPI. Readers may immediately recognize that deficiency of factor 8A is the cofactor deficient in classic hemophilia, and that factor 9 is the cofactor deficient in type B hemophilia or Christmas disease. In the absence of these intrinsic pathway factors, inhibition of the extrinsic pathway by TFPI cannot be overridden by the action of the intrinsic pathway, and patients with hemophilia will bleed because continued generation of factor Xa is hobbled. Although in patients with hemophilia the extrinsic pathway is not defective, TFPI turns off the extrinsic route so that further generation of factor Xa is dependent on the intrinsic pathway. As emphasized, the two pathways of blood coagulation converge to form a common pathway which leads to the generation of the central coagulation enzyme, thrombin. It is thrombin that catalyzes the conversion of fibrinogen to fibrin. Final stabilization of the fibrin is the responsibility of factor 13, which is a transglutaminase which catalyzes the cross-linking of the two chains of fibrin. Why has the intrinsic pathway been relegated to a supporting rather than starring role in blood coagulation? It comes from the clinical observation that individuals with inherited deficiency of the contact activation factors, factor 12, prekallikrein, and high molecular weight kininogen, do not manifest clinical bleeding, even though their partial thromboplastin time is markedly prolonged. We should note that individuals with deficiency of factors 11 and 9 and 8, the last two factors in hemophiliacs, do suffer clinical bleeding. We have already considered that the amplifying role of factors 9 and 8 in perpetuating blood coagulation after TFPI has shut off the extrinsic route. And now let's continue with the discussion of regulation of blood coagulation. Unrestrained explosive activation of the blood coagulation system could cause the entire blood volume to clot in less than a minute. In the face of such a catastrophic outcome, it is expected that there are several factors that control, localize, and restrain blood coagulation. Integrity of the vascular endothelium with its anti-thrombotic properties is a major factor in keeping clotting localized at the site of vessel injury. Because thrombin is the key protease enzyme of the coagulation system, most of the regulation of coagulation is directed against formation and function of thrombin and involve antithrombins and the protein C/S system, both protein S and protein C. Antithrombin 3 is a serine protease inhibitor, a SERPIN, that targets serine proteases, including thrombin and other activated coagulation factors, by inactivating key aspartate serine residues at the enzyme active site. In the presence of heparin, the rate of binding to thrombin is increased 1,000-fold. Heparin and heparan sulfate are normal components of the vessel endothelium. The protein C pathway also regulates thrombin production. The components of the protein C pathway are athrombin, thrombomodulin, protein C, and protein S. Protein C, when bound to thrombomodulin, is activated by thrombin through limited proteolysis. Thrombomodulin is a transmembrane proteoglycan that binds thrombin, removing it from the circulation by promoting generation of the active form of protein C, or active protein C, APC. Protein S is a cofactor of APC in the inactivation of factor 5A and 8A, both of which are involved in generating thrombin. Deficiency of antithrombin 3, protein C, or protein S is associated with an inherited tendency to thrombosis. In addition, factor 5 Leiden deficiency is a common thrombophilic disorder in which abnormal factor 5 is resistant to proteolysis by protein C. And now we will move on to discuss fibrinolysis. Fibrin is not the end product of the coagulation system, but it is formed in inflammation and during tissue repair. When no longer needed, it is essential that fibrin be removed, especially to restore the patency of vessels where clot formation had sealed the tear. The enzymatic breakdown of fibrin is termed fibrinolysis and is carried out by the enzyme plasmin, which is not surprisingly a serine protease. The precursor to plasmin is the zymogen plasminogen. Notably, when fibrin formation begins in a clot, plasminogen binds to the fibrin, accumulating in the clot. Tissue plasminogen activator, or TPA, also binds to fibrin, and this surface enhances the ability of TPA to convert plasminogen to plasmin. Another enzyme, urokinase, which is urinary plasminogen activator, or UPA, is believed to function with tissues to keep hollow organs free of clots, e.g. the ureter. To emphasize, there is little plasmin formation until fibrin begins to form, and this requirement confines plasmin generation to the clot, preventing plasmin from forming throughout the circulation. Plasmin dismantles fibrin in an orderly manner, starting from the outside of the chain. The fragments released are called fibrin degradation products, or FDPs, and fibrin split products, or FSPs. Notably, FSPs are potent inhibitors of clotting and play a role in the pathophysiology of disseminated intravascular clotting, or DIC. Two serum proteins, alpha-2 antiplasmin and alpha-2 macroglobulin, inhibit the action of plasmin to ensure that it does not